Emergence of the nuclear family, that option is no longer available. So the home healthcare, it looks as if it's going to be a it's something that developed organically, responding to a need in the market. Something that was developed organically without being planned for it, it was bound to have a lot of characteristics that would be very diverse and so on. So that is what this study came up with. What we also realize is that there's a market for home healthcare, or the prevalence of home healthcare is going to be different from context to context, depending on the degree of demographic transition that has happened, the epidemiological transition that has happened, the social change that has happened. So there's a lot of work that still needs to be done in trying to understand this. Initially, we'll go through a presentation of what the findings were, and in the discussion that follows and the group discussion to which all of you are invited to contribute, we'll try to tease out some of these issues, and also try to see what further work we will needs to be done collaboratively in partnership with all of us. Now, so to present the report, I hand this over to the Health Systems Governance Group.
Oh, I'll just share the presentation.
We will present the findings from the study that we have carried out. Sonali will start with the presentation. Sonali Dhava, she's a research associate in the Health Systems Governance team at HSTP. And after that, I will carry on the presentation once Sonali finishes.
So the presentation and the full screen is visible, Pallavi?
Yeah, but not full screen. Can you make it full screen?
Wait a second. Just give me a minute, please.
Yeah.
Is this now full screen?
Yeah, it's fine. Yeah.
Okay. Thank you so much, Rajiv sir, and thank you so much, Pallavi, for the introduction. So as both of them have laid the foundation of why we exactly started with home healthcare study, I'll quickly begin with a brief of a background, what's the status currently in India, the objectives, the methodology, before we go into the findings. So as we learn from home healthcare, from the global experiences, it is something which is provided to ill and infirm people to promote, restore, rehabilitate the maximum level of comfort and function and health in their homes. This is what we understand as a home healthcare. It encompasses everything from personal care, preventive, promotive, therapeutic, rehabilitative, long-term maintenance care to palliative care. Everything is being provided within the homes. If we see the global experiences, it has shown that the demand increases with the changing demographics, disease profile of the population, and the social cultural transition. For example, in Sweden, it started in 1950s when they started providing home health care to elderly people with the household duties and personal care without having them to move to a nursing home. In Japan, it started with 1970s when the home nurses began the home visits. Whereas in USA, it originally started to reduce the hospital stays and facilitate the early discharge. But later on, by 1980, it was evolved more, and the services were also provided for the long-term care of persons with the chronic diseases. So overall, the goal is to provide quality, appropriate, and a cost-effective care to people at their homes, enabling them to maintain their independence and quality of life. Similarly, we see in India. Do we see the next slide?
No, yet it's not changed.
Sorry. Something is happening. So if we see in India, currently the elderly population is on the rise. We have already 10% of elderly population aged more than 60 and above, which is about more than 104 million in India. And states like Kerala, Tamil Nadu, they are predicted to have higher elderly population compared to other Indian states. There's also a rising burden of non-communicable diseases. There's an early onset of NCDs in the age group of 45 and plus. And because of this, there's a proportion of death caused by NCDs also on the rise. In 2016, it already constituted about 61.8%. In the same time, the cancer burden is rising. It is projected that we have 6 million people who are estimated to need palliative care in the country annually. As of now, we have 26.8 million differently able persons in the country, which is about just 2.2%, but 62% of them, they are projected to require a caregiver. In the COVID-19 pandemic also, the need for home healthcare was established. And if we go by the market reports, the sector is estimated to reach about US dollars 21.3 billion by 2027. So we see, given by the global experience, that there's a changing demographics, there's a changing epidemiology, and the market for this is also increasing. So with this, we did a study. We realized that there is a need and there is a response. The sector is also growing, but there is a very little documentation of how this overall sector of home healthcare is organized in India. With this, the specific objectives for us were to understand what exactly encompasses home healthcare and to understand the interaction between the users, the providers of home healthcare, and the various organizations who are engaged in the home healthcare. So we looked into the services that are being provided at home, who are the users of such services, who are providing home healthcare services at home, what are the different kinds of organization, and to explore the opportunities and the barriers which are there while delivering these services. So we undertook an exploratory descriptive qualitative study. If we go by the work of Stebbins and Sendelvoski, we realize this approach is recommended when the aspects of healthcare practice that have received previously little or no attention is a good approach. So by this, we used EDQ approach. We conducted review of literature, we conducted in-depth interviews, and we also did expert consultations. So before we went to do our interviews, we defined the key terms where we defined what will be a home, what is home healthcare service for us, what would be a provider, and organizations engaged in the services. So by this, we used the purposive and snowballing sampling to identify our respondent groups. They were identified from home healthcare companies. They were identified from non-profit organizations, hospitals that have a home healthcare department or a unit or a program, nursing bureaus, and also training institutions who are engaged in delivering training for the home healthcare providers. So we had a sample of 27 respondents, of which 18 were female and 9 males. 4 we interviewed were the patients and the family members. 8 were providers. Sunil, can I please request you to mute your mic? 8 were providers, which had nurses, nursing aid, physiotherapists, palliative care doctor, counselors. 11 had representations from organizations who are engaged in delivering such services. 3 from training institutions who provide vocational training. And 1 was from an accredited organization, which currently accreditates home healthcare companies in India. So with this, we had representation from Delhi, and 3 of our respondents were based out of Chennai, Bangalore, and Kochi. Data collection was done last year between February and March. We used semi-structured interview guides. 24 were in-depth interview, and with 3 we had expert consultation. So all of this we coded using a qualitative software in Vivo, and the entire study is reviewed and approved by the Institutional Ethics Committee of the Health Systems and Transformation Platform. So with this, I'll hand it over to Pallavi. I understand there will be questions to this presentation, but we'll take either by the end of the presentation, or maybe we could take just after the panel discussion. So please put your questions in the Q&A box, or you may put it in the chat box. Pallavi, over to you, please.
Yeah. Thank you, Sonali. So right now my video, I suspect that the voice quality is not very good, probably because of some disruption with the internet connection. So I'll switch off my video in between if there is a problem with the audio that might make the audio better. So to pick up from where Sonali left, we'll share some of the findings that we found through both the literature review and the in-depth interviews and expert consultation that we did. And we understand that this is going to give an overview of what's happening. It is not an exhaustive study. And while most of our respondents were in Delhi NCR, but many of them are engaged in delivering services in other parts of the country. To that extent, it is not just Delhi specific, it also gives a larger picture. At the same time, we would not claim that this is a representative study or an exhaustive study. Okay, with that disclaimer, I move on to share the key findings as to what did we find based on the research questions that we had. What are the services that are being provided in home health care? So one of the main services that we came across was the assistance with activities of daily living and instrumental activities. And this was along with routine nursing care. Routine nursing care includes services such as monitoring of vitals, dressing of wounds, and bed sores. And there has been a change in the nature of services that are provided over the last decade. That has changed, as one of our respondents here mentions, that in the last 8 to 10 years, clinical services are also now possible at home. So there is a growing provision of post-hospitalization care, intensive care, monitoring, stabilization services, palliative care. Palliative care has been provided at home from before rather also, and physiotherapy services. I will change the next.
Yeah.
So some of the commonly performed specialized procedures at home that we found: plastic surgery, dressing, nasogastric tube insertion, catheterization, dialysis. And during COVID, a lot of attention was received by home health care. A lot of care was provided through these services in different manner by providers, through teleconsultation, by provision of medicines, prevention kits, etc. And as we were told that earlier, people used to be scared that if a critical patient is taken home, then how would the patient be managed? And therefore, it was only ADL that people were using at home, but that scenario is changing. There are even ICU setups being provided at home. And nurses who are trained in ICU services often can provide different types of services. They are well trained to take care of critical patients at home. So these were some of these services. Who were the users? Related to the services are the users, because ADL and IADL are the most commonly used services. So the most common user group is the elderly, and the other groups is the people who've been discharged from hospitals or after post operations or surgeries or treatment for any acute illness, and they need follow-up care at home after discharge from the hospital. Services at home are also used by bedridden patients, dependent patients, pregnant women, new mothers, young newborn children, and people with acute or long-term physical or mental conditions. And during the pandemic, of course, people with COVID-19 were the key users of home healthcare services. We'll come to this later as to what do we constitute or understand as home healthcare, but home services at home, home healthcare services, these can be from short duration to long duration. And short duration could be as short as a wound dressing or just frequent injections. And long duration services could range from several weeks to even years. So basically, the patient's condition is what dictates the duration of home healthcare services. Mostly people learn about these services through the word of mouth. And when people are in hospitals, admitted in hospitals, they are given information about home healthcare companies or people who can provide services at home by the hospital staff as well. The providers who we learned about are providing services at home. So they can be categorized into 5 groups. Family members, as we all know, are the first point of care for anyone when they are ill or sick. We have programs by community-based outreach workers, both by government and non-government organizations, who deliver different kinds of services, from screening to some basic intervention services. What we focused was on the other 3 categories of providers: the untrained aides, attendants, amongst them being one, who are primarily responsible for providing ADL and IADL related services, and they do not have any formal training. They mostly learn with experience. Another category is that of trained caregivers, people who undergo vocational training. So they are trained to provide ADL support and deliver basic patient care, and they are maybe referred by different nomenclatures: home health aide, geriatric care aide, general duty assistant. So there are several such nomenclature depending on which vocational course they undergo. The professionally qualified healthcare workers, such as doctors, nurses, physiotherapists, counselors, are also involved in delivering care at home. Amongst these, what we found the most common were the untrained aides and the trained caregivers, which is in sync with which are the most commonly used services, that is ADL and IDL, along with routine nursing care for the elderly. And hence, the most common providers are these untrained aides and the trained caregivers, though there is a greater now demand for these trained caregivers. And as one of our respondents told us, that the greater demand is for attendants than for professionally qualified healthcare workers. So it could range anywhere between 80 to 20 or 85 to 15 for geriatric, for trained caregivers, and lesser for nurses. And the caregivers can work either independently, they may be hired directly by the family, or they may work through organizations. Organizations like Sonali mentioned some of them, and we will come back to what we learned about the functioning of the organizations in a while. Regarding the trained caregivers, which we found is one category of providers which is growing. There are vocational training courses for such caregivers, which some of our panelists will also talk about later. So I'm not going into that right now. How are they different from the others is that they cater only to the patient's needs and they do not perform any household work. They are skilled to provide, as I mentioned, ADL assistance to the patients, unlike the untrained aides who work without training and learn by experience. However, they are not trained to perform surgical dressing, oxygen administration, catheterization, gastrotomic care, or emergency or critical care. They are not trained to provide such services. Though we did learn that families at times put pressure that they also administer injections to patients, which we don't know if they may still be doing, or ideally they should not be doing that. GDAs, the general duty assistants, who are also trained to work in the hospitals, work at home as well, and are trained to provide certain services. So these are some of the experiences that our respondents shared. Coming to the organizations who are engaged in home health care. So in our study, we've categorized into 4 groups. There may be others that may be added to it. This is what we learned. So there are hospitals which have a home health care department, or even without a separate department, may be providing services at home. There are home healthcare companies, non-profit organizations, and nursing bureaus. So the organizations, they offer services from routine to specialized nursing care. They can provide intensive care, geriatric care as in specialized services, or they may provide routine and common services, including assistance with activities of daily living. What we found about the functioning of the organizations, most of them, they prefer to work through temporary providers who they hire on need basis, and on-roll staff is usually lesser. And that is because having staff on roll increases the organization's liability. As one of our respondents told us, then they have to follow the rules for PF and ASI, give them paid leaves, which they say would increase their charges and in turn would increase the cost to the user. So for that reason, they prefer to work with providers as temporary. They bring them on board as and when needed, and or work through vendors, as this person is sharing. However, in the process, what happens is these trained care or these providers do not get organizational benefits because they are not on the organization's rolls. Next, please. Yeah. Some of these organizations we learned have developed their own internal processes, because as we'll come later, I'm sure most of you know, there are no standard guidelines laid down or SOPs laid down for how to provide care at home. So some of the organizations have done that for themselves in terms of the services that they provide. Some of them follow processes like they would conduct a medical assessment of the patient, an assessment of the home, provide training to the providers, conduct their supervision. And some of them also enter into a written contract with the users, though most of them work on verbal understanding. And the organizations that provide very specialized care, they may also have a care plan, which like one of the respondents told us, is a living document and it changes as per the patient's condition changes, but the care plan lists down what all needs to be done to take care of the patient in terms of medication, procedures, at what frequency, what needs to be done. The need for referral was very common among the elderly patients, of course. However, the responsibilities of the family to take the patient to the hospital in case of an emergency, and it is the family's decision. The provider or the company or the organization may help with referral if the family so wants, but the responsibility is of the family. And in deploying providers, although we did learn more, we are sharing a bit here. Some organizations match the provider to the patient in terms of whether men, women, what is the age group of the patient, what is the requirement in terms of care. And so some, like one respondent said that if it's an old patient, male patient who's older, then we send a female nurse. Otherwise, for male patients, we do not send female nurses. But this was a contradiction because some patients said that, some respondents said that they do send female nurses even for male patients, because that is where the demand is. And I'll come to the issues of the provider in a while. This also leads to some issues, concerns for the provider's safety. Coming to how the sector is financed at present. So the cost of care at home is a concern right now. Most of the services are provided by the for-profit private sector, while specialized services like intensive care, so an ICU in a hospital may cost more than when it is set up at home if one needs. But the cost of hiring a caregiver for 12 hours or 24 hours is considerably high. And especially if it is professionally qualified, trained people such as nurses, then it is even more. So right now, most of the cost is borne by patients out of pocket. Though we didn't go into the details of the role of insurance, that is something we think is work for future to understand what role insurance can play in increasing access to home health care. But the Insurance Regulatory and Development Authority of India, it recognizes domiciliary hospitalization in certain conditions, mainly that either the patient is not in a position to be taken to a hospital or the hospital doesn't have beds, which is what happened during the COVID period. So though it is not mandatory, but some private insurance companies, they include the feature of home health care in their packages. And since it is there is no compulsion, they are free to add conditions and limitations when they provide such covers. Some insurance companies are partnering with the private companies to deliver home health care. But as I mentioned, this is an area that does need to be understood better, because we also learned that there are certain concerns of covering home health care under insurance, because what do you define as home health care and how much will insurance cover and pay for? In terms of, like I mentioned earlier, there are not guidelines, not laid down, or SOPs on how to provide care at home. The Maintenance and Welfare of Parents and Senior Citizens Amendment Bill of 2019, that would bring in some structure to the process. Some draft standards have been put across. Again, some of our panelists will talk more about it, so I will not get into it here. But in one of the questions that we set out to understand is what is home health care, which is still open, and we think is work for future as to how do we understand what is our understanding of home health care in the Indian context. When responding to a question by the standing committee, the Ministry of Social Justice and Empowerment answered that home care services can have a large scope. So it includes home health care aids, diagnostics, doctor visits, physiotherapy, including food and nutrition supply, terminal care, counseling. So there is a whole vast scope of these services. So there is a need to understand, identify, come to a common understanding of what is home health care in the Indian context, because there is often medical care and then there is social care. So is it only medical care? Is it a combination of medical and social care? And how does one go about organizing these services better? In the absence of regulation, accreditation of some private home healthcare companies has taken place by organizations such as the QAI and JCI. They put up some standards for accreditation, and some organizations have been accredited. But however, there are no, like I said, protocols or SOPs to provide care for specific conditions, whether it is intensive care, palliative care, or any other condition specific to the patient's requirement. So each organization or provider, they develop their own procedures and follow their own processes. Some of the other challenges that we learned in delivering home healthcare services, one is the availability of providers and trained providers, because people who have to spend long hours in patients' homes, they need to have a certain kind of certain kind of maturity and empathetic attitude. And how much ever one may say, this can get very tiring and taxing for the provider. So one of our respondents told us that वो दीवार उसके लिए जेल की तरह हो जाती है. So especially if the family does not give the provider time off, then it can get very stressful for the provider to be working 24 hours in the patient's home. Respondents shared with us their concerns with regard to safety in the patient's homes and dignity and respect. Especially some of the nurses have this concern of working in home health care, that the families do not treat them with respect. And so they are reluctant to work in the home environment, and some of them then prefer to work in the hospitals, even though working in homes may pay more. Handling of emergencies, as I shared earlier, is a gray area. It is left to the family to decide and to move the patient in case of an emergency to the hospital. Management of biomedical waste. Now, because home is not identified as a site of healthcare, there is no obligation to manage the biomedical waste generated in delivering healthcare at home. So that, as of now, most organizations, they dispose it off as regular home household waste. Though we did come across a couple of incidents wherein the provider takes back the waste generated to the organization central office, and from there it is disposed of. But in most cases, it is done with the regular routine household waste. Because there are no processes or SOPs or regulations, so there is an absence of grievance redressal mechanism, both for the users and the providers. Quality control of services was raised as a concern by some of the respondents. And as I mentioned about the costs, the reach has been limited because of that. And therefore, some people did say that it should be covered under insurance, under Ayushman Bharat. But those are issues that need further deliberation, whether that is possible and how that would be possible. So one of the respondents, like they said, that in a hospital, if there's an emergency, patient can be managed because there is everything. At home, that becomes a big limitation. Going forward, what we think would be helpful to do, one is that, as I mentioned, that this study provides an overview of home health care. And there is a need to delve deeper into some other aspects, and there could be further studies taken up to understand the user's perspective better, the provider's perspective, what is the profile of providers, what is their motivation to work in the home healthcare sector, what would help them retain and gain interest in working in home healthcare, the supervision and training provided to home healthcare providers, and the accreditation and quality aspects. These are some of the issues. In our report, we've highlighted some more. So there are other issues that need to be understood better. As Rajiv mentioned, that this is an area that we do want to work on further. And what we feel from our findings and from our studies, that there is a need to develop a common understanding of what constitutes home health care. Because also in terms of terminology, there is home health care, there is home-based care, it is home care. So home health care could mean essentially healthcare or medical care, clinical care, but social care is an important aspect, an equally important aspect. So what should constitute home health care in the Indian context? Internationally, different countries have taken different models. Then guidelines or SOPs on how care should be provided at home. While for hospitals, there are some procedures in place, but at home, what all should be done when a provider goes home? What are some of the non-negotiables and care quality parameters that need to be followed, both so that safety of the user, the patient, is maintained and of the provider is ensured. And then standardized procedures to deliver condition-specific care at home. Those would also help the organizations and providers in taking care of the patients better. So with this, I'll end here. And if there are questions in the chat box, we can take them now, or we can take them later on along with the panel discussion when we open up to the audience.
Pallavi, I think there are a few questions, and it may be a good idea to take some of them.
Sure.
One of them is that did we, at least on a sample basis, make an estimate of the quantity of biomedical waste and what type of waste are generated, and and what's happened? That last part you have responded. That is, what is happening to the waste? You have said what is there, but any idea of the quantity of waste? This is significant. Maybe that's a question.
Yeah. No, it is, but we did not get into this aspect of how much is generated, what all. It depends on the procedures that are delivered at home. So if there is a dressing being done, there is catheterization being done, accordingly, it would be the waste generated, but we did not get into the specifics of this at this stage. But it would be important to understand, yes.
No, and Shyamala, and since we know the procedures that are being done at home, it's possible to extrapolate and estimate the amount quantum of waste that is generated. Ajay has a suggestion for you, which is that we need more quantitative data as well. Ajay fully endorsed, and going forward, we could work together to generate this data. It'll be interesting to see what percentage of care is being provided by. And then the other question that came up on the QA was
one of them is, could you please tell the different categories under home health care?
Which was there in the slide before. So Pallavi would like to recap that, the categories.
Yeah, so again, categories could be categories of providers, services, users, what different types of home health care in terms of medical care, social care, as we have been saying. So in terms of services, we have ADL, IADL, instrumental activities, assistance with daily living activities, routine nursing procedures, specialized procedures such as dialysis. They're also provided. Then there's palliative care at home being provided. What we didn't go into in depth here, and how the family manages someone at home. So there are some organizations that run courses for families to manage people with mental health conditions or physical disabilities. There are these different aspects of home health care, and accordingly there are different providers. They are trained, untrained, vocational providers with vocational training, providers with professional training. So, which is what we mean, that one needs to understand and have a common understanding of what does home health care actually mean, because you also have community health workers going into people's homes and either doing screening as part of government programs or non-government programs, and also providing intervention. I mean, to that extent, even an ASHA doing HbA1c could be considered as home health care, but is that what we would want to consider home health care in this context?
Right. The other question is that, do you need registration to start home health care? In anywhere in India? That is the other question. Do you need any registration? Is it?
So we did find that some organizations have registered under the Clinical Establishment Act, but we were not able to understand it further as to how does it fall within the Clinical Establishment Acts. I see a question related to KPME. Yeah, so probably the reference was to KPME, but I am not sure whether it was the state specific KPME or any other state, but it was on one of the clinical establishments regulations. But this needs to be understood, because in one of the meetings of the National Council of the Clinical Establishments Act, it was very clearly stated that home health care will not be covered under the Clinical Establishments Act. So that is again an area which needs to be further understood and then deliberated upon as to what would be the best option.
Right. Now we're running out of time for this, but we'll take two more questions. One is, did you estimate the time the family members spend on caring, whether there's a paid carer or not? Was it possible from the user's perspective?
Yeah, so like I said, that we did not get into that kind of, for the limited study that we conducted, we did not get into it. But user perspective and understanding the family's requirement is, as we flagged, one of the areas for further studies and understanding. And as someone else also highlighted earlier, just to add here, that to do a need assessment of home health care, what is the need assessment? So far, we are going by the data that we have in terms of demographic changes, epidemiological changes. But whether we need a study on the needs assessment at the community level is another open question.
Right. Now, and Rema has asked you whether, based on your study, is your study adequate to arrive at a typology of home health care as well as map its diversity?
I won't say it is adequate, but it can definitely help be a starting point for it, and then we add to it. It will provide a wide range. It can be a good starting point for us to do that. And of course, there will be more that can be added to it. But from the literature review and what we learned from our interviews, it can be done. Yeah.
Yeah, maybe one of the things that we need to do would be to look at different other contexts and then see, to validate the typology. There is a typology in their study, but it'll be good to validate it in other places and then come up with a more comprehensive one. And we have a response from Tom George, who manages home health care, that in their organization they take the waste back. And Dr. Shaji has a question that, is there a greater preference for the night home health care than only the daytime providers? Did you find anything like that?
We did not find anything specific like that, but I won't say that is not so, because we didn't even ask a specific question to that effect.
Right. Okay, thank you for responding to the questions. And can we take it forward, Sonali? What is the?
Yeah.
Yeah.
Yeah. We now start the panel discussion.
We start with a
Yes.
panel discussion. Yeah, Sonali, over to you.
So just one brief point. I think Dr. Gaurisan Gupta would be joining us shortly in between. So in the meantime, I'll introduce our other three panelists. We have Madam Kavita Narayan, who's currently serving as a technical advisor to the National Human Resources for Health Cell, Ministry of Health and Family Welfare, Government of India. Her relentless efforts for the allied healthcare professionals have actually resulted in the passage of National Commission for Allied and Healthcare Professions Act 2021, with the goal to create opportunities for 56 plus types of healthcare professionals in the allied healthcare category. She has been instrumental in creating the blueprint for implementing the Health Ministry's vision of Heal by India in 2021. She's coordinating the capacity building efforts during the pandemic and has also served on the India chapter of the Lancet Commission on COVID-19. And as one of the youngest and the first Indian fellow of the American College of Healthcare Executive, she has more than 20 plus years of experience as a hospital and health systems architect and a thought leader in India and the US. Second, we have Dr. P.K. Jamila. Ma'am is currently serving as the member of Kerala State Planning Board, who is in charge of health, Government of Kerala. With a career spanning over 37 plus years, ma'am is a pediatrician by training and has worked in the various positions in the Kerala Health Services. Before retiring as a Directorate of Health Services, she was the Superintendent of District Headquarter Hospital, Public Health Administrator as the DMO and an Additional Director of Health Services. And post her retirement, she has also worked as a State Consultant for the Adra Mission, NHM, Government of Kerala. And currently we also have with us Madam Anupama Datta, who is serving as a Head Policy Research and Advocacy, HelpAge India, and has been working with the organization for more than 2 decades. She holds an MPhil from JNU University, and a major thirst area of work is research and mainstream the issues concerning elder persons. Her findings on elder abuse, impact of disasters on elderly, and the social securities have been used to sensitize the policymakers and legislators to take appropriate actions. And she also used all these findings to assist the elderly population group in articulating their interest in order to make the appropriate demands. And she's also the editor of HelpAge India Research and Development Journal and has published multiple articles on aging and various books and journals. I see Dr. Gaurisan Gupta, she has also joined us. Okay. So Dr. Gaurisan Gupta, she's a public health specialist and a deputy director general at the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. She is the National Technical Program Officer for the National Program for Healthcare of Elderly, National Mental Health Program, and National Palliative Care Program. Dr. Sen Gupta has previously worked in the various capacities for Planning Commission, Vardhaman Mahavir Medical College and Safdarjung Hospital, St. Stephen's Hospital, and Central Health Education Bureau for National IC plans for health programs. She's a medical doctor with MD Community Medicine and DNB and a postgraduate diploma in Health and Family Welfare Management. So with this brief background, Rajiv sir, I hand it over to you for the session.
Thank you, Sonali. Welcome to the panelists, and I hope all of you have been able to listen to the presentation. And what we'll try to do is to address some of the issues that have come through in the presentation, and your response to it based on your rich and varied experience of the past. We'll start with Dr. Gaurisan Gupta. Are you there, Dr. Gupta?
So I think we have lost her.
Okay, so Kavita, you are in the same building as Gauri is, so I think I'll come to you next. One of the major issues that seems to have has come out in this presentation is a lack of standardization. Lack of a standardization regarding the qualification of the people who are providing services, on quality, on grievance redressal mechanism, etc., etc. In fact, the whole thing, the whole scene seems to be, what shall I say, a highly unstandardized, unregulated, not regulated more or less. It's most of the places unregulated anyway, but highly unstandardized and a description that lacks a lot of clarity. So what is your perception on this? Your perception of what is actually happening? Is it as unregulated as our study shows it is, And what is the way forward in trying to bring some bit of standardization so that both the providers and consumers are able to work in a mutually satisfying environment? Over to you, Kavita.
Thank you, sir. Pleasure to see you. I thought I saw Sunil there also for a brief moment, but I think he disappeared in video. Pleasure to talk to all of you. And I did have a chance to chat with Pallavi earlier and was I'm very happy that there's been a study, sir, of this very, very important kind of, this sector is so critical, and very good to see that there's at least an initial study. So yes, I mean, of course, there's lots more that we need to do, but considering the size of the market, as we all, sort of love to, sort of look at, $340 billion market is this market worldwide. The reason I know this now, more importantly, is because as we're looking at Heal by India, we are looking at sending our people all over, looking really at the global context, and as G20 shaping up, etc. There is such a huge need of home health aid, geriatric aid, the whole sort of realm of this, not just here, but all over the world. This is truly sort of a very, very large emerging issue, problem, as well as opportunity, right? As you see it for multiple areas. But I think in terms of, and I heard some very good questions, and honestly, I had some answers as well for some of the questions that had come through. And maybe what I can start with is saying that it is not true that there are no standards, sir. I think there are a lot of standards. But as you are well aware from your past experience, the gap that we have between putting in place standards and implementation is so huge. I think that's where I think our challenge is. So Pallavi, I think I shared with you when we were chatting last week. So one of the work that we do, that I do in the cell in the ministry, is we are the nodal agency for standardizing all of the skill curricula that are related to health. So any skill course that is related to healthcare, the agreement that we have negotiated between Ministry of Health and Ministry of Skills is that even though skills, the Skill Sector Council basically, and the Skill Ministry is what runs the healthcare skill courses, every single curriculum comes to the Ministry of Health for vetting. That's the standard, the process we've had for the last 4 to 5 years. And I have personally sat and looked at, along with my team, over 107 different types of curricula, whether it is a biomedical technician, whether it is a home health aid, geriatric aid, and all kinds of home health aids, etc. So there is a lot of these areas that are there, and I'll come back to the issue of nomenclature as well. And sir, at any point you can just tell me, hey, you have 1 more minute, we can take it forward. But maybe I'll take a couple of minutes and give you more of a context on this. So the process that we employ is that all of the curricula gets reviewed by experts from across the country, including and under the chairmanship of the Director of General Health Services. So the DGHS is the chairperson who looks at this curricula. We have very clear standards, what will be taught, changing the patient's linen, moving the patient, transporting, bathing, eating, feeding. A very, very clear curricula and standards have been put. Biomedical waste management is a whole chapter of 100 hours that they're supposed to do. So there is a lot of this content that's actually available and has been done in the last few years. And this then goes through multiple levels of curriculum committee review, and then gets adopted by the Sector Skill Council and the Skill Ministry. So that is how so in fact, there are several curricula that we actually simply just rejected. And they said, this does not meet our technical specs, so we cannot. For example, I think one of the people asked the question as to what is the right, clinical scope, like does there scope creep that happens? And as you're well aware, it happens all the time. So, you don't want a home health aide to be going and administering an injection, or, trying to start an IV line, etc. So we in fact even have put a never list, saying that these are, will be the never list of what you shall not do. So all of this is there on paper, and it is there in terms of a standard. And if anybody ever goes to the Healthcare Sector Skill Council site and looks at something called the National Qualification Register, it's called the NQR, you will find all of these standards are well laid out there. And 47 such courses have been approved by the Health Ministry. So I was just coming in terms of the standards. And currently, in fact, there's one course from Kerala, Madam Jamila, I think you are probably well aware. One of the courses is actually from Kerala. Because I mean, in terms of the states that have done the most work in terms of old age palliative care, I don't know.
So sorry to interrupt you.
Yeah.
What you're saying is this: you've done your work. That is, the standards are there, but
Yes.
are not getting implemented.
Yes.
So what is your take on how do we move from the standards that are available to what actually gets rolled out? Any suggestions on that?
Sir, I think one important area is, the communication. So even though this is like with many of our schemes, right? And I think Dr. Gauri Sen Gupta is also there. one of the things is people are not aware often, right, of these standards. And as you are well aware, in this particular space, it's a very, very private sector dominant space today. There is no real, public policy on it. It's not really a, public finance scheme kind of thing. So today, if anybody wants, in fact, right as we speak, my father-in-law, 92-year-old, I have an ICU nurse and I have a home health aide in my house right now. So that figures that I saw, 1 lakh a month and 40,000 a month is, we are sort of looking at it going, oh, wow, this is what we all are spending, because I'd rather that than spend 1 lakh a day every day in the ICU, right? That's what we're looking at. So this is the only available option. And we have even government folks saying, hey, how do we, find this kind of help? So I think,
Right.
sir, the key gap here is that the communication, particularly to people who are teaching such courses and employing. So I think we have a lot of private employers on this call as well, I hope. I think there is a gap in terms of ensuring that they are well aware of what these standards are, and that when they are employing, the employment should be based on these, particular, you have to be checking off to say, yes, this person knows this and this. I'll take 30 seconds. Right. During COVID, we made about 10,000 calls to various healthcare, such professionals to see if we could back them up. I can tell you that we couldn't find over 8,000 or 9,000 of them. They were fake numbers. They were all sort of in some sort of black hole. We couldn't even find them. So just accumulating and keeping a good database like we have for the other, regulated professions is very, very critical for these skilled folks as well, because it is very quickly going away from a unskilled, semi-skilled to a very skilled and, sort of professional space. So okay. I will stop there.
Yeah, thank you, Kavita. And now that you put everything back, put everything back on the provider, I cannot help but call Anupama to come in and see what she sees about the sector. What Kavita says is that all those arrangements are in place. It's the awareness that needs to be done. And from where you stand, I'm sure you see a different kind of picture. That is in terms of what's available in the market, what is the policy environment that kind of governs the sector, and what are your financing from insurance, etc., etc. So from the point of view of a provider and someone who's been researching this field, what do you think is the experience of the providers in terms of their experience of the policy and other supportive environment?
Thank you, Rajiv. I think I agree with Kavita in the sense that it's completely in the unorganized sector. And I would say that it's a very new thing to have happened in this country. This is like, care was always the family's domain. It's very recent that you're now employing people from outside to take care of your family members. I think that's one reason. And second is that we have not regulated this sector. There is also resistance from the sector, I think, because like Pallavi was saying, and like Kavita was also agreeing, that most of it is in the private domain. It's not in the government domain at all. It's very few people are in the government domain, mostly private and unorganized. And it's an organic thing. Like, it has, because there is need, the market responded to the need. And that is why, because there is no regulation, you are paying through your nose to keep your parent in the right space. So these are some of the aspects that happen. And then there was this attempt, I can only talk from the point of view of elderly care because we deal with them only. So there was this attempt by this review legislation, which Pallavi mentioned, that there should be regulation of home health care, there should be regulation of old age homes, and there should be regulation of other bodies that are providing caregivers. But unfortunately, this review legislation was never passed by the parliament, so it's still hanging. So at the moment, we do not have any body or any legislation to regulate this trade. That is one. You may train them, you may do anything, but who's saying and who's supervising? Who's supervising whether I'm training or I'm using untrained people? And like, the thing is that, if you use untrained people, you pay them less. If it goes into the organized field, you have to pay them according to the rules. You have to do so many other things. You have to do refresher course. It's like becomes like any other trade. But at the moment, it is not at the level of any other trade. It is completely in the unorganized zone. And because those who have got whatever degree or little diploma that they have, they're charging enough money, which people can't afford. I mean, tell me which elderly person in India can afford a 1 lakh rupee nurse? You tell me. And we are dealing with the poor people and the not so poor people. And women, if you, because, it was not mentioned here, but feminization of aging, if we are looking at that, how many women have the capacity to pay that kind of money? And they are the ones who require this care, because by the time they are 80, 85, everybody is gone. So these are the challenges that lawmakers, policymakers, government, community, everybody has to think about it. But what I can suggest, what I can tell you from experience is that community can play a very big role here. Like, we have this in Kerala, like ma'am may know, and in Tamil Nadu, we have this palliative care groups, of young volunteers who help people in their community deal with these challenges of life. So are we looking at something like that? Family, how many family carers have been trained? I don't know. There are many courses that are available to family carers, like, short courses like 3 months, 2 months, 1 month, where a family person can be trained to take care of the elderly. So these are some options that we have to look at, unless you really want to push it to the market. If you want to push it as a service to the market, then please treat it as service, as organized service, and then regulate and completely take it to that domain. But it is neither here nor there, and it's creating a lot of problems.
Thank you, Anupama. Dr. Jamila, lots of demand on what we need to learn from you. I'll come to you later. Because right now, Anupama has raised an issue that it is for the government to, a very important issue of what happens to, old age, elderly people, especially the feminization of aging, which is a fact, and then what happens to palliative care patients, etc., etc. Fortunately, before I come to you, we have Dr. Gauri Sengupta here, who is in charge of the elderly care and the palliative care program. So, Dr. Gauri, this is a direct request or a direct, direct comment that points to what you deal with, and from where you, from your vantage point of managing the elderly care and the palliative care program, and certainly mental health also. Where do we go from here? I mean, how do we take care of the needs of a real need and not leave it entirely to the market?
Okay, at the outset, thank you so much. And I'm so sorry for joining in late. You all must, I really apologize to everybody. My daughter is giving her board exam, so I have to shuttle her and all that stuff. And once again, thank you, sir. It's great meeting you, not through NPCC PIP meetings and on such platforms. And it's lovely to talk in technical forums rather than just to talk about fund utilization and how much a fund has been given. So lovely to hear Kavita speaking, and of course Anupama speaking. Anupama has already raised two issues that I wanted to raise, that yes, this sector has no regulators. So we have the private sector and we have the government sector. So I'll stick to, firstly, I'll have two comments. One is the government sector. I'd like to let you know that under the program, I'm sure all of you are mostly aware, but under the healthcare of elderly program, we have a lot of components, specifically now with the Ayushman Bharat Health and Wellness Center. So we have a big team, which if you go through the operational guidelines, home healthcare or home-based care has been integrated into it seamlessly. So it's not just the ASHA or the Anganwadi worker or the MLHP or the staff nurse or the CHO who's going to do. Every single person has defined roles. But more important than that, there is another concept also, that is of peer support groups. Like we have wonderful examples from Tamil Nadu. I'll again go back to that same state, where you have peer group of elderly women who actually take care of medication and taking people who are totally bedbound, taking care of those in groups of 5 or 10. So there are lovely examples across the country. I do have lovely examples of Sayyas and Sayya Sathis. These are from Jharkhand, and these are government functionaries at the grassroots level. And they are like, they take care of one another, one level above the other, taking care of line listing of all the people, not only elderly, but palliative care also, or end-of-life care also, people who require home-based care. So those kinds of things. So that is there. As far as the elder care is concerned, we have ensured that there is a proper trainings are there. There is a regular monitoring. There is a regular assessments, line listing. We have developed a continuous comprehensive geriatric assessment and care booklet. It is something like what we had in the erstwhile days of a health diary concept. At least for elderly, we feel that something of a kind of a health passbook should be there with them, so that even if they are moving from one place to another, or if you are being referred right down from the health and wellness center to a tertiary care center or even to a district hospital, there is something which you are carrying which will assist anybody, even if it is just a medical officer or if it is the topmost specialist, to assess and give that kind of care, specifically in case of people who require home-based care, because then the caregiver or the family member will be actually taking that to the person and getting the kind of medical care that is required. So the referrals become very easy in that manner. Secondly, for palliative care, we have across the country, we didn't go about creating one specific norm because every state kind of developed, like, for example, you have the palliative care units, like one physiotherapist and one staff nurse from Tamil Nadu. From Kerala, you have a completely unique model in which you've got a wonderful example of social welfare and health ministry and Panchayat Raj, everything together and delivering palliative care to the extent of nursing palliative care right at the houses of even the single people or destitutes and all those kinds of things. Now, apart from that, we have other models also in all the other states. So as far as the government sector is concerned, my only concern has been trying to developing the quality of the care kind of standardized as per the state requirements. So again, I'm sure you know better that what works in the south of India does not work in the north of India and can never work in the east of India and the northeast of India. So a lot of very good examples, and they are still in the process of work, because I would still say that having had the honor of having the elderly care program for the last 6 to 7 years, still I would say that palliative care and elder care is not a priority. It's not a priority area. And it comes as a priority only when it tends to hamper the daily living of maybe the family members or maybe the person concerned, or if it becomes a long-term care proposition at the institution, at the hospital level, if you feel that now the patient is like more than 2 weeks, it's been there, and now there's nothing else that we can do, and the person requires home-based care. So this is another sector which we need to work on. Coming to my second point, in case you'll give me 5 minutes, one thing which I really wanted this August gathering and all the participants also to consider is the other side of home-based care. Like I was speaking to Pallavi yesterday, I've had a mother who was 83 years old, fell down, had a fracture, very small fracture of the neck, and was on a Philadelphia collar for more than 14 days. Now, unfortunately, she was given buprenorphine for pain. She started vomiting. So you had to remove it, clean it, all that stuff was there. Within, say, maybe a month, she was okay to move around and everything. But just because she had a home care attendant 24 hours of the day, it was impossible for me to rehabilitate her to actually start walking on her own. For everything, she wanted the assistant to be with her, even to support her through physiotherapy. And it took us more than 3.5 months for her to actually come out of it. And mind you, she's a very strong lady. She's an ex-army and wonderful of that sort. And touch wood, since then till date, it's been more than 1.5 years now. No issues. Second thing, people requiring home-based care, we are forcing a lot of assistive aids. We keep talking about assistive aids and technologies and all those kinds of things. We know all the barriers, we know everything, but the take-up of it, utilization of it, and actually home care aids using it or promoting it does not occur. So home health care needs to be defined. I would say 2-3 definitions. First is for bedridden people. And then it is for homebound people who are not bedridden. Maybe a COPD patient who has to have 4 nebulizations 4 times a day. cannot go out of the house because of that, but that person is not bed bound. So I'm not worried about bed sores or those kinds of things. I'm more worried about keeping the person active. We've seen that in COVID. Secondly, home care may be required for acute conditions. It may be for only 2 to 3 weeks, or it could be for chronic, say maybe 3 to 6 months, where I know that this is the time limit for which I need an attendant or an assistant of any kind of skill. And last comes end of life care, for which I know that I need a person perpetually till this XYZ person is going to maybe pass off. So there are a lot of diversities in the home healthcare sector, and I wish we would really be able to define these. And more important, last point which I want to make is actually have people demand those kind of services. Even in the private sector, nobody demands that the home healthcare person, even if they are trained, this is the minimum kind of work that they should be capable of. Even if you're paying for them, we do not get that kind of quality, right from portier down to any other low level of bureaus and all employers, which they provide all the caregivers and all. We don't demand those kind of healthcare seeking services from such home care attendants. We are actually grateful that at least we've got somebody who's taking care of them. So I think it's about time we have the double-edged kind of a thing, that where the supplier is also responsible, but we are also demanding those kinds of services, like what happened in Kerala. So if you demand for those kind of services, I'm sure we'll be able to up the quality and the regulation also. So thank you so much, sir. I've taken a lot of time.
No, thank you, Gauri. That was a wonderful exposition of various issues, and it will be really benefited by your contribution. And now we come to Kerala. Dr. Jamila, so much expectation, so many, it can't be transplanted. Now, what Kavita was saying, that this is what is waiting for us, is already on Kerala. Kerala already has about 15% of the population aged above 65. The acute cases that that require rehabilitation is very much happening in Kerala. Palliative care is very much there. So quite a challenging situation. So what is Kerala government's approach or strategy for dealing with this as we go along? And what role does the home health care providers have in providing that? Over to you, Dr. Jamila. Have we lost her, Sonali?
We just lost her. She was here while.
Yeah, she was here when Raji was asking,
Yes.
inviting her. I'll just check with her.
No, she will be just having this thing coming back.
Connectivity issue.
Yeah. And Dr. Gauri, I don't accept that what is happening in the South can't be replicated elsewhere. All that my organization pushes for is that we need the political will. We need people that need something to happen, and as you said, people who demand service. So please don't tell the audience that what happens in the South can't happen in the rest of the
No, sir, if I may interrupt, all I'm saying is that a model needs to be replicable, but more importantly, sustainable. We may be able to replicate the Kerala model, but to make it sustainable, like you rightly pointed out, we need all the three parts of the triangle. So if suppose I have to put it in the north, I need to have that same kind of healthcare seeking behavior from the people also. They need to demand those services. And I need to have a workforce that is as committed. So I would say that I have a lot of good examples in the other states also. That's what I was saying.
Yeah, okay,
so,
yeah, that's right. The states have to reinvent what they.
Yes,
Yeah,
each state has its own positives.
Correct.
It has its own positive.
Exactly. Thank you. Otherwise, you would make our life very difficult. Now we work with states,
no.
and then if you tell me this can't happen elsewhere, then we are out of work. So that's
never.
That's the kind of thing. Great. Now, while we wait for Dr. Jamila to join,
she's joined.
Yes, I have joined.
Okay, great.
I lost the connection.
Yeah, Dr. Jamila, Kerala is there both on the demand side and supposedly on the supply side. We may agree or disagree on that, but In terms of demand, 15% of your population is aged above 65. A large number of acute management that needs rehabilitation, a lot of end-of-life care needed for palliative care. And in the strategy of the government of Kerala to deal with this, and the situation will get even more complicated going forward, what do you see as a role of home health care as a part of this? Over to you, Dr. Jamila.
Yes, first of all, thank you, sir, for the opportunity. I would like to congratulate HSTP for such a study. Though it is a limited study, it opens so many questions in this sector. As you already mentioned, we have 15% of our older population, and it is estimated that it will soon become 20% in the coming years. So actually, from the part of the government has never shown any deep interest in the care of elderly, even though the population is so high. And of course, palliative care in Kerala is very good, and each panchayat has to take up the palliative project. It's a mandatory thing, otherwise their other projects will not get approved. So that is going on. But when you come to the panchayat level or at the grassroots level, our estimate is that around 50 to 60% are there in each panchayat or each 30,000 population who needs this care of especially elderly, not the others. 90% of them are elderly only, or 10% comes to the other chronic illnesses or accident cases, victims, etc. So this is a very grave area. Actually, as mentioned in the study, there is no regulation, there is no standardization, there is no definition also. Here in Kerala, the domestic care and the healthcare are mixed up. Many untrained persons are engaged in domestic as well as healthcare. The same person will do the domestic job like cooking, cleaning, and they themselves will give the healthcare also. So I'm happy that you have some generic definition is established. What is the domestic help and the other is healthcare. Here in Kerala, we are going in for some regulations on the domestic help also. So we have to differentiate between the domestic as well as the healthcare. That is one thing. Second is the demand side is huge, but the supply side is very poor. We have a lot of untrained human resource. But actually, as mentioned by Kavita ma'am, we have not only one more training curriculum, we have different types of training curriculums adopted by different agencies in the private sector. And they are not standardized at all. And some are scientific, some may not be scientific, some are spiritual also. Spiritual part also comes in. It is based on the religious groups. Like spirituality also comes into a big part of the care. So it's not scientific. Third thing is that regulation. Even our clinical establishment bill caters each and every nursing home and each and every nursing centers. We have not, and laboratories, dental clinics, everything is included, but we have not included the agencies who give home health care. So that is another area we have to explore more. We have to bring all this into the regulation. At present, what we understand that when the planning board inquired about this regulation or a registration thing, we understood that the labor department has some registrations. That is actually for the welfare of the workers, providers. Providers have their security, their salary, etc. The minimum wages and all. And on the agency side, actually they registered just like any other agency. And some of the agencies are registered in the panchayat. But that is also not standardized. So what I think is that we have to have standardization, especially for the quality, and we have to have a module for each and every service provided. It could be daily routine care, or it could be instrumental care, or it could be nursing care, or specialized care, or it could be post-operative care, or it could be the terminal illness care or whatever it is, we have to have standards and training curriculum should be ready for each and every care rendered at home. That is one thing. Second is registration. That is mandatory. Actually, the government is not aware of how many agencies are there, how are they working, what is the salary, and what is the financial burden by the beneficiary also. Even in Trivandrum, we can afford nurses only if we pay 1 lakh rupee. That is the rate for BSc nursing care for 24 hours in Trivandrum. And the rate goes down as the quality decreases. Because if it is untrained, we can have 15,000 to 20,000. If it is trained, it again goes up from 20 to 30 to 40 to 50. And for highly qualified nurses, we have to pay even 1 lakh rupees per month. So that has to be regularized. And we have to provide these facilities, home care to the poor people in the community, those who cannot afford. If one person, daily wages workers, if the son and daughter or whatever, who are the family members are working for daily wages, how can they provide care to their parents at home? So that this has to be decentralized, and the panchayat has to take the responsibility of providing home care to the needed, to the really poor public. Because for a treatment, they can come to the government hospital and take treatment free of cost. And with Ayushman Bharat, they can have, even in private hospital, treatment is also affordable for them. But for home care, there is no provision in Kerala, even in Kerala. So that has to be settled. So these are the thinkings of from the planning board point of view. And we are going in for an initial survey. What is happening in the state? Who are the agencies playing in this sector? What are the different types of services they are rendering? What is their quality of standard? And what is their training? And how they are charging? And we have decided to take the data from the provider side, from the agency side, as well as from the client side or the beneficiary side. So, and the main objective of our state is to have a regulatory mechanism, then standardization of care, improve the quality of care, and also to provide care to the real poor who cannot afford monthly payment on monthly basis.
Okay, thank you, Dr. Jamila. Now, I'm slightly curious. On the one hand, we say that the supply side is very poor. That the adequate number of people are not there, and then we say it costs a lot. Now, why isn't the market stepping in to provide these services? No, because if there is an opportunity, there's a need, and it's a highly lucrative kind of thing, then why isn't the market stepping in? Dr. Anubama, any suggestion, any your analysis of why the supply continues to be constrained?
See, there are a couple of things here. One, like I said, it's something very new. We are not used to market responding to care, requirements of older people. It was always in the domain of the family. So it's something like in Hindi, we say seva. This is like a seva, like, it's in the charity domain or it's in the family domain. So market is new. So, and second is that it's not lucrative in that sense of the term, because I think that's what the kind of feedback I get from the people who are training caregivers is that nobody wants to do the dirty job.
Yes.
Nobody wants to do that dirty job. If they say that if family members are not willing to do it, why should I do it? So even those who get trained, many of them just take it as a certificate, to be added to their CV, but they do not actually go and do that work.
Okay.
And second is, and there's another issue of other speakers have also referred to it, is that there is no platform where you can match the demand and the supply. I may be trained, but do I really know where do I go? How do I how do I get a job? Like there is no platform. Like there's an urban company which tells you that if you have a certain skill, we'll put you on our platform. You can offer your services. People will come and take it. But there is no such platform here which offers you this opportunity to show the market that you are available for providing the service. So these are some very broad challenges, I think, which from supply side, if we really want to improve this market response to care, then it's important for us to look at these aspects also, because I know many, I'm sure many of you know this. National Institute of Social Defense used to run a course like that. For a long time, they continued to run this course for caregivers in elderly care space. And that was one of the basic challenges they were facing, that they were unable to place these people into, remunerative jobs.
Right.
So
Same thing
that's
happened with
something.
the Red Cross also. Red Cross also ran a course like this and closed down almost for the same reason. That brings us to another question, and I will open it up to any of the panelists. One of the major problem is that paying for it, because the lack of paying capacity of the clientele who are elderly, earnings have come down, and it becomes very difficult to sustain. So one option is that government government steps in and pays for it, as in their study they mentioned about Sweden. Are there any other financing mechanisms that can make it support this? Are any of the panelists aware of any other financing mechanism that would be helpful to finance this in the long run?
Okay. What about insurance in this field, sir? What about insurance?
Well, I won't respond to that. I will throw it open to the house.
No, if I may, I'd like to comment on this. Jamila ji, I think you should. I don't know. Do you know the kind of premium elderly people have to pay to get just that simple service that is available as of now? It's prohibitive. It's prohibitive cost. So insurance company will never ever pay for that. They're into business. They will never invest in something that returns are like, they will have to actually pump in money back into this if they start paying for care. So insurance is not the route. It's just not the route. Especially the private insurance companies is not the route. Public insurance, I don't know, PMJY. No, the cost itself is the major inhibiting factor in this, because it's human resource, it's it's money. A couple of years ago, I'd like to just quickly share this thing with you. A couple of years ago, Rehabilitation Council was trying to develop a course on caregivers, and there was a big dilemma that what should be the nomenclature given to this person who is a carer. Is it something who is just somebody who has just passed class 8 and is providing service? Is it somebody who has done maybe graduation? Because if you say I'm managing a healthcare, then the person expects a much better remuneration. And if you say class 8, then are you saying then the problem of people being used as domestic services, along with care services and regulation, yesterday we were discussing offline with Pallavi, that many of these caregivers who are placed in homes come back and complain that, the family tries to treat me as a servant. I'm not a servant.
Yes.
So where, and you are bringing a law that is going to regulate domestic, service industry. I think challenges are almost similar in both cases.
Right.
Because it's unorganized. Where do you draw the line? How do you say that this is not my domain, this is my domain? And who will regulate? Who will oversee? Who will supervise? So these are some very basic challenges. And safety and security. Do I have a police mechanism to back this up? Supposing there's a report of assault on either party. How do you deal with it? So there are some, like financing, of course, I'm digressing. Financing is like something, I think it has to be financed maximum by the family. You have the Maintenance Act where you can say that family is liable to pay if they can pay. So state will only pay for those who can't pay, like in the public sector. But family or self, I think these are the only two ways that we can support it. Otherwise,
right.
That's my view.
Can I request the panelists to stay on while I try to pull in some of the panelists some of the participants who are on this. Ajay, I know you are the macroeconomist, the health economist on this area. So would you like to come in and make, and do you have any, I mean, this is an extremely difficult question and worth all your expertise. So Dr. Ajay Mahal is a well-known health economist. I see him on the panel. Ajay, can you pull you in for your response?
Sure, why not? Can you hear me?
Yeah, certainly, yeah.
First of all, let me congratulate each and every one on the panel, as well as the two presenters, for what I thought was a very engaging discussion. Personally, I learned a lot. I simply came onto this session to understand what's going on. In general, I think this is a hard problem. There are many kinds. I just want to lay out the problem. Economists love laying out problems, not solving them. So I think first of all, smaller family sizes. So it's not simply about relying on the family, because if you have only one kid, I mean, the biggest, strongest thing that's happening in India right now is declining fertility across all states, including in UP and Bihar. So one can't hope to have family as a sole source of support. However much we want to care about our parents and so on, you've got to have some supplementation of that activity by other sources, whether it's peer-based support or community-based support. I think we can learn from countries such as Malaysia and so on, which are very similar in what we do and the challenges they are facing. That's one. I think the idea.
Ajay, we seem to have lost you. We can't hear you, Ajay.
He's on mute. He's put himself on mute. Could you please unmute yourself?
Yeah, sorry, I did that because I had my music going on the side. Okay, but let me simply say that I think the idea of long-term insurance, care insurance, is going to be an awfully hard one. I think already, from what I can see, I mean, between PNG and health and wellness centers, unless the government is really putting in serious money, let's say twice what it's putting in right now, at least overall as a percentage of GDP, I think this is going to be a pipe dream. I think our hope has got to be in the short run, family-based support, perhaps learning, somebody mentioned peer groups and so forth. That's going to be the short-run approach. But in the longer run, with the long-term demographic changes, we have to think about how we can, bring together additional resources and pool in more people from the informal sector and so on. I think this is a hard problem. I wish I had a magic solution to offer you. I don't. So I'm going to just keep my mouth shut and listen to you all.
No, Ajay, I just want to hear you say that there's one problem at least that you can't, offer a full solution to. Anyway, but seriously, do you think a long-term, universal coverage, from in which there is a cross subsidy between the younger population and the older population? Because the advantage is that, except for few states like Kerala, the dependency ratio is still manageable, and we might still be able to do it. I mean, theoretically, would that be possible?
Okay, so my response would be that we should not think of long-term care as some different animal from the broader challenges that are facing the health sector. I think it has to be a multi-pronged approach to manage this thing. So certainly addressing NCDs, addressing issues around, people transition to disability as they get older, postponing, health problems to a later date. So I would say a major effort has to be put in on health promotion, health prevention, and so forth. That's got to be an important part of any solution you can think of. The second thing has got to be, how do we address this issue? Many elderly living in the rural areas, poor elderly, women elderly. This is a major challenge. I think it's got to be a mix of methods. In some some cities, some states, it might be the family. In some states, it might be government services. A mix and match of methods will have to work. There is no one particular solution, is my sense.
Yeah, okay.
As we speak, but it's got to be a health sector combined with the social sector, improving continuity of care, ensuring that there are sort of halfway houses that lead you when you get discharged from hospitals. You don't land up in the house, and so on. I think so. We might have to sort of think about balancing a whole range of things in the health sector, the long-term care sector, and in generally, and that's how I see this. I don't see it as relying on a magic wand. No.
Thank you, Ajay. That's quite helpful. Your comment is quite helpful on that. Now it's time to bring in one of the practitioners in this area, somebody who's been providing services. Mr. Tom George, what is your comment on how the long-term sustainability of addressing the need. I'm not talking about the sector, but addressing the need for home healthcare, how that is going to be met. Mr. Tom George?
Thank you. Thank you, Dr. Rajiv. Can you see me and can you hear
certainly
me?
I can. We
Yes,
can see
yes.
you and hear you. Yeah.
Okay. I think I missed you in between while I was joining the.
No, we are all theoreticians sitting on the bank and commenting. You are actually there trying to run the show. So what, according to you, would be one, the policy environment that are supportive? We saw your post on this thing, but it'll be good if you can detail that for us. And secondly, the long-term solution to address this issue, because everywhere, sooner or later, the dependency ratio is going to become unsustainable, and we don't have a long-term health insurance. And what Ajay recommended in terms of health care, quality leaves a lot to be desired. So from that and what you say from within the industry, so what do you think would be the policymakers? What are the areas that you think the policymakers should focus on, trying to stave off this challenge to the extent that is possible?
Yeah, thank you so much for having me, and thank you for having this kind of a discussion. I really wish such discussions on home healthcare happens more often, because from last 11 years that I've been in this business, I'm one of the pioneers in Kerala in terms of professional home healthcare. And while we approach the question, and some of the panelists already mentioned about it, I approached district medical officer to find out what is the regulation when I started this. And he said, yeah, good that you are starting something like this. I said, okay, nurses, doctors will be going home and providing healthcare services. Yeah, wonderful. So I said, is there any license, anything required? Nothing, you go ahead and do it. And I can tell him to please write it down and give it to me. So I found it out the hard way in terms of whatever little I can do to ensure that I am complying to whatever ground rules that are there. So, like somebody mentioned, Labor Commissioner Office was the first place to go. There I registered. Health departments within the corporation of Kochi. That is where I found one place wherein I have to be registering myself. And similar other places, like, the moment you have 10 people or more, ESI comes in, Provident Fund comes in, all of that. But before anything of that kind, what I did little bit is in terms of modeling it on a US home healthcare, because that is an established place. So two things I found at that point. One being, for applying for license, there are two insurances required even for home care in US. One being professional indemnity insurance and the other being fidelity insurance. Now, I went about asking for professional indemnity insurance for a home healthcare company, and the insurance company said there was no product for it. I did not even have one service agent go out of my office premises for another 5 months until such time I got this product created. New India Insurance, I got it through some broker to create it for me. Fidelity, yes, I've had one instance of fidelity happening in the last 11 years where somebody stole something, and I can proudly say for last 9 years, the client happens to be still my client. 24/7 care is going on, though the first fidelity instance happened the first year itself. I could retrieve it. Now, what I'm trying to come to is, yes, as a private provider, I could make an effort because I don't want to put my head down in shame and go off business next day. So I ended up doing this, but it's not easy. Again, I train folks. I would have trained more than 1,000 people in-house, and I lose out there. And they're going out. I mean, I'm training, even as we speak, we are training 4 batches of 10 each every month, and more than half of it, they're all going abroad. Some of them are MBAs, going to become care assistants in the UK. Now, I'm giving some silly, I could tell you, I'm trying to give them a 15-day training and put them on a 3-month internship. Okay, now I'm sure that GDS also, I want them to go through my training, because I see this, Kavita ma'am, I just wanted to say that okay, GDS and all that, there is a lot of things that government has done. But unfortunately, while implementation point, people are looking at the numbers. So they're getting anybody and everybody in. The biggest qualification a carer should have is the care attitude. If that is not there, you're actually risking somebody's life. And when I train folks, I tell them, please don't get in if you don't really have the care attitude. I'm giving you a skill which you can utilize even in your personal life. That much is worth. This training is worth. Otherwise, don't get in. And I think I've taken, a whole lot of time.
Certainly not.
Passionate about it.
So Tom George, our study is over, but we are still booking you for an interview. We need to pick your brain. We need to learn from you on your experience, and that will be invaluable. One final question is, yeah. One
thing I wanted to add, sir, is that in 2017, I think, there used to be some home healthcare summits that used to happen under one of the organization's aegis. There used to be 2 home healthcare summits that happened, one in Mumbai and one in Delhi. And the first one, I had actually presented a small presentation, very, very, skeleton, but a framework for home healthcare. I think it is still relevant, and HSTP with its, panelists of experts and panelists and the reach that it has got, this is something that would help the entire ecosystem. We're talking about carers, we're talking about government, all of them put together under a framework.
One of the things we are trying to we will be trying to do is actually, we are a platform, so we want to bring people together. So what you just made suggestion is great for us. Thank you for your contribution to this. And
my pleasure. I'll be happy.
Yeah. Any of the other participants would like to come in? Rema, you had this question on the feminization of domestic work. There was also this question of feminization of aging, and actually the emergence of home healthcare, I believe, was because the feminization of care was kind of came down. So would you like to respond to these questions that were raised?
Thank you very much. I think I really enjoyed the presentation and the discussion. I want to just suggest that I think it's very important to what the speaker before me said about actually defining our ecosystem and its boundaries. The reason I'm saying this is that we are talking about home care, we are talking about care for older persons, which is home-based, but we are also talking about it in a social context. And I think the point really is to bring in this question of which class of people are we really referring to. It's very clear the markets are responding to the needs of the middle and upper middle classes. And so we are having a very fragmented ecosystem in terms of the demand side of the story, as it were. Now, the other very important aspect is, I think there has been a lot of work on feminization of domestic work. And in fact, I'm sorry, the person from HelpAge made a very pertinent point about how it was earlier the family's responsibility to care, whether it is for older persons or for the others. But there's a very gendered aspect to caring. And that, of course, has been put under enormous stress with nuclearization, etc. But I think the third very important part of the ecosystem, which Ajay Mahal spoke about, is the financing of it. So how do you integrate health and social care? And I mean, I've done some work in Shanghai, which is very fascinating, where they do have, for example, because they have a very robust public insurance scheme for health services, nearly universal, they have also extended it to covering home-based care for older persons. So they actually have public-private partnerships very clearly defined for home-based care. So I'm just saying that in this story of the ecosystem, we have to look at the stratified nature of the market itself. I mean, I'm very familiar with Coimbatore, where I've been, in fact, trying to do some work. So whether you look at, it's a continuum between assisted living homes with agencies which are, from Portia downwards. you have multiple actors and agencies. And because there is this stratified need, you have this kind of a situation. And lastly, I want to say this blurring of lines, especially with older persons, between domestic care and home-based care, which is required for someone who is sick, is extremely blurred. We are doing some work for the APO WHO in Kerala, and one of our interviews, when we interviewed people who are home-based workers for older persons, they said, you know, we face the wrath in the home in which we work. We also face the wrath in our family, because they say, oh, you're going and doing dirty work in the homes of these, the families in which you're working. It's seen as dirty work because you are cleaning people up. You are, so all I'm saying is that maybe an interdisciplinary framing is very important to define the ecosystem. Sorry if I've taken too much time. Thank you.
Thank you, Ramana. That's extremely useful. Now, I noticed that I've been inviting people that I know, so I'm sure there are many others who like to speak. Would anyone? Would anyone? Many of the people who've been commenting on the chat boxes. Would you like to come in and vocalize, voice what you've been saying? Otherwise, I go back to my practice of inviting people.
We have Nayanjeet Chaudhary one.
Yeah, she's raising her.
Yeah, please go ahead.
Yeah, my name is Dr. Nayanjeet, and I'm a public health professional and a medical doctor. There has been a lot of requests from known
We seem to have lost you.
He's here, but he's muted.
Am I audible?
Yeah,
Yes,
no,
yes.
yeah.
My name is Dr. Nayanjeet, and I am a public health professional and a medical doctor. I run a public health innovation center. And I do receive a lot of requests from known circuits around the country to help set up home healthcare services. I've never been into this, venture at all in the past. Just that people, like my help in different other non-profit sectors related to health, so they approach me. Now, my request to the panel is, if there are interested groups, is there an ecosystem? I know that there's no concrete ecosystem, but now that this long webinar has given us a lot of hopes, is there a potential ecosystem that can support new sort of groups, either in the non-profit or in the startup sector, to take it up? And what do the panelists advise so that I can relay this to the groups? Thank you so much.
Mr. Tom George, are you aware of any support system that is available for new startups who are interested in this area?
See, I'm not, honestly speaking. Services sector are not really supported in terms of, if you're talking about funding, it is very difficult, except now recently we have been identified by, government of India has one senior care growth engine, senior age care aging growth engine or something. SAGE is a thing that they are trying to provide some sort of a supplementary funding for organization. There are certain criteria for that. I mean, we are working towards that, but I don't think a funding perspective there is anything available. I mean, not that I'm aware of one, but the challenge seriously is there are, I mean, at least most of the metros are having about 5 or 6 home care companies starting every month, and 5 or 6 companies or more of them closing down every month. So sustainability in terms of sustaining this practice is not easy. My attrition levels could be anywhere more than 90 and all at times, especially COVID. I got half my staff went away. Now we are slowly recouping back. And biggest challenge that I see is, as an organized player, I am required to follow all the statutory requirements of ESI, PF, and all of them, and still work with individuals who are very erratic at work. So they might turn up, they may not turn up. So how do you ensure? So that is a bigger challenge. I'm taking up continuous care, and I do not want to tell the client sorry. I will not, never say.
Right. Would Dr. Gauri or Kavita, are you aware of any support system that's available?
I'm happy to jump in here for a minute, only because I think we get to Mr. Tom George as well as Mr. Chaudhary, lots of private sector funding agencies, so like a Sequoia or all of these people. As you very rightly said, every week we have, if somebody is seeming to have a startup or something that is coming up in healthcare, the only reason we know is a lot of times they ask for, is there some curriculum? Somebody will put them through to me to say, oh, what do you actually need to do? So a lot of times I think the funding is given before even people know what is to be done, right? Which is because that's the kind of phase we are in right now. However, I think I'll bring it back to this problem, right? What is our intent really? Because I mean, as somebody who, was introduced, we work so hard. Many of us in this place have all worked on putting together legislation, but it is very appalling because the gap between the legislation and the implementation is so large that we are again talking about all of these, sectors and funding for such a small group of people. I mean, the large majority are still nobody is going to be able to pay, 20 and 30,000 and 40,000 a month or whatever, the 1,000 rupees a day for care. So I think we still have that hard problem that Mr. Ajay Mahal was mentioning earlier, which is of what is the financing and what is the government's role for the larger group, right? And how do we actually make that happen? In the meanwhile, though, knowing that there is a very large population of kids who are all going out of the country, there is, a lot more financing that is coming in. Children want their parents to be taken care of, when they're in America or Sweden or wherever else. This market is really growing. So people are very happy to say, okay, let me just put my guilt money of $500 a month or $1,000 and take care of my parents. And this is happening in tier 1, tier 2, everywhere. And that's how I think, these sort of ecosystems are not really there formally. But I can tell you, I'm happy to offline connect you all with whoever I know, because many of them reach out to us to ask for some basics. Actually, I think what they're trying to make sure is they don't have any regulatory issues, but really the funding and the startups are happening on almost on an everyday basis. So lots of questions come to me, but not that we can really help more than we basically say these are the standards. We keep continuing to tell them the same thing. I don't think we are really solving the problem as such, and I'm being pretty transparent about it. I hope that helps. Thanks.
Oh, thank you very much.
Would you like to respond? Dr. Gauri, would you like to add to this?
Yeah. Okay. Coming from that, partly agreeing with what Kavita had said, as far as I said and other things are there, one big issue is the dichotomy which is there, because healthcare needs to be provided by the Ministry of Health and Family Welfare, whereas the regulatory mechanism and all the other aspects related to the social sector and everything lies with the Ministry of Social Justice and Empowerment, so the Rehabilitation Council of India, Ministry of Social Defense, all sorts of things, funding to regulation, to training, to actual involvement, everything happens. So whenever you have interministerial or interdepartmental, you've got a lot of players that need to talk to one another. So that creates the massive confusion that is there. So like Tom had said, yes, Ministry of Social Justice has come out with a lot of schemes in which there is a lot of money involved, and there are a lot of platforms where you can get for innovations and also for home healthcare. Again, I would like to come back to what Kavita had said and what others have also been talking about. We need to define what is it that we need to provide. Secondly, to whom we need to provide, and for how long to be needed to be provided. That is the first thing that we need to define. Secondly, where and how is the regulation going to be? So tomorrow, if suppose we consider that even the Ministry of Health or Ministry of Social Justice or XYZ, any organization, even if a CSR funding is coming, banking sector, insurance sector, everything comes in. How do you regulate it? Tom correctly pointed out, you will have all of us can start a center. It's not an easy, it's not such a difficult thing. Maybe we need to put in a little bit of stuff and a little bit of effort. But then how long are you able to sustain it? What is more important is, why are these people getting trained? So it's just not possible for us to sustain this particular model of getting hold of people, training them, and actually expecting them that they are going to continue with these careers for even 5 years or maybe 10 years. NISD, I've been involved with them for more than 10 years in those same courses of geriatric care assistants. They started with 40, they came down to 20. And right now, I think even the 10 or the 20 that are getting trained, I personally could not even employ even one of them for my own mother. So again, finance, I wouldn't say is a matter of concern for the agencies to spring up. But who's going to regulate them and who's going to sustain them? If it is my personal business, I may be invested in it for the profit, or maybe if it is a not-for-profit, for some other benefit. So one thing which I feel, and we are trying to introduce it, is how do you create that space, or how do you create caregiving to be something which is not to be looked down upon and something to be looked up to? So when you talk about Sweden and all the Finnish countries and all these things, a lot of incentivizing things, like they have wonderful examples of time banks and youth people. And there was this wonderful a proposal that had come in for co-location of orphanages with old age homes, and we had recommended that. So I think we can come up with very good ideas in the next 2 to 5 years, so that within the decade of healthy aging, we can come up with different mechanisms. When I say what works in Kerala may not work in the north of India, same goes for what works in the Southeast Asia or maybe in Americas. The same model may not work, but we can come up with a regional model. So I think if we can put in incentivizing in some manner, caregiving, making it a kind of a respectable thing, making it kind of incentivizing it in, say, not only monetary manner, but some other benefits that can be given with the education sector. If we are expecting the youth and the adolescents and other people to actually invest their time in it, do we need to, we also need to give them something in lieu of that. So I think we need to look into that ecospace, and I don't think it is possible for us to create a sustainable model which can be, monetized and run by few people in the private sector or even in the government sector. So I think that is something which we all need to look at. And secondly, the thing which I keep saying, I know I keep harping at it from my program perspective, is that in the Indian perspective, we never plan for our old age. That is something which is never talked about. So if we are looking at even 3% of the population, we're looking at 90%, 90 lakhs or so requiring some kind of home-based care. And even in that, if we are looking at 1 to 2% requiring totally bed-bound care or something of that sort. So it's not such a big deal. I think we can promote. Under our program, definitely we're going to come in with awareness generation for that, that we need to start talking about not only health promotion, healthy lifestyle and other things, but planning for your maybe 60 plus years. So catch hold of them at 40s and 50s. Be ready for it. If you know you're a diabetic or a hypertensive for more than 5 years or so, be prepared for it. God forbid you need that kind of stuff. So I think we need to find out a lot of other mechanisms also. Thank you.
Thank you. Any final comment from you, Anupama Datta?
Yeah.
Ma'am, you have muted yourself.
Oh, sorry. I just hope that this legislation gets through the parliament this year, at least this session or the next session, so that there is some semblance of regulation, because I think regulation is the starting point. Unless you regulate, it's not going to solve at least the supply side channels, I think, and that's very important. And of course, a lot of work is being done on the skill side. I think government has taken it up as one of the skill development activities. So a lot is happening there also. Like you have a lot of agencies that are coming in and are training people. But unless you regulate it and unless you put it in the legislation that if you're running an old age home, if you're providing service, these are the basics that you have to, go by. It's going to be very fuzzy. So I think that's something that I'm expecting at least to happen. And of course, there are other issues, like I said, feminization, paying capacities, Gauri said that how much are we, how much are we prepared for our old age? And I think more and more people, but I think here we also need to talk about preventive healthcare, active aging. What are we doing to do that so that very few number of people require this kind of, assistance or assistive living or what have you. So those are some broad areas that on which we need to think, because like any demographer will tell you that this is not a problem that is distant. This is going to happen very quickly to India.
Yeah.
And we have not actually put our minds to it. We have done sporadic things here and there, but we need to actually look at, as a society, we need to find a response that is that maximizes benefits.
Thank you. I'll give the final word to Sunil Nandaraj, who was the advisor to the HSD that actually carried out the study. So Sunil, please come in.
Yeah, thanks, Rajiv. I didn't want to come in, but some of the panelists and some of the participants had raised certain issues. And I thought I'll bring in some of the concerns which I really feel. One is, I think it boils down to what is the role of the state, whether it is a provider, financer, or a regulator. And many people have spoken about regulation. Bill, I think we need to really look at regulation with a word of caution, because I think we'll have to really look at the capacity of the state to regulate. We have seen the case in many of the legislations, implementations, the government has failed, including the latest, the Clinical Establishment Act. I mean, where are we with that? We did all those fantastic regulations. So I think we will have to look at the capacity of the state. When I talk about the state, I'm talking about the central government and the state governments to regulate. Does it really have the capacity to regulate? Second, I think very important that regulation needs to address some issues of concern, especially with this area. Type of service. Are you talking about regulating individual providers and organizations, including corporates who supply human resources or manpower services? Type of services. Are we trying to regulate simple with high-end services? What is the kind of services? It starts with simple, being with that patient or the person, or just carrying to really highly specialized. Simple thing between, again, rural and urban. I think we will have to really look at that entire issue of rural-urban. It boils down to Bharat versus India. Now the middle class is getting hit. This is a middle class problem, or it's not. Who's getting really hit? I think we will have to really, I know that it's also rural and all those. Are we talking about, when we talk about regulation, trained versus untrained? What do we, where do we draw the line? Are we trying to ease out the entire untrained, those who are providing care? Registered, unregistered, organized. I think I'd just like to raise these issues, that how is regulation going to touch upon these very specific issues? Because this came up in other areas also. I would like to also bring to the attention, maybe we would like to look at other forms of provision, aggregators, like where we have urban clap or whatever. We would like to look at other forms of provision of services. Now what they are called aggregators. One important point in the entire discussion, which I think may have not have come up because in between I lost the connection, is the entire grievance redressal mechanism for both the providers, individual providers and the users. Where do they go right now? Which law covers them? Do they cover under Consumer Protection Act? Where do they go? I think grievance redressal is one major thing. And the last point I would like to, since this is an area which has got various dimensions and tangential issues, I think one of the important things is, can we look at how do we come together, various organizations, individuals who are looking, and explore and see how do we address some of these issues, whether they are standardization, whether you're talking about legislation, whether you're talking about bringing curriculum going up to the state level, or even finding out who is registered, who's not registered, how many are functioning. So I think now the time has come, Pallavi and Sonali. One of the things that I would really like to see from this webinar is, how do we bring various people together? As Rajiv always says, We are a platform. And I think we need to look at that. And I leave it to you, Rajiv. Thanks a lot.
Thank you, Sunil, for flagging those points. Frankly, this discussion has taken the issue far beyond what our report did, and I really thank all the panelists, Dr. Gauri, Kavita, Dr. Anubama, and more importantly, or equally importantly, the people who contributed on the chat box, people who came in and shared the experience with us. And I think this is an issue that while we are a research organization, we can't provide solutions, but we can highlight those issues and bring people together, take this forward. And I'd like to, we would like to take this forward, explore these issues further. And maybe there was this comment that I could not come to from Hyderabad. Like there are people studying this in different areas. How does this look in Bangalore and Hyderabad and Mumbai? All this would be different. So it'll be good to bring this together, and hopefully let's see how we can work together. Once again, thank you, Dr. Gauri. Thank you, Anubama. Thank you, Dr. Jamila, Kavita, and all the others who joined us today. Let me hand you back to my team, Sonali, for taking it forward. Thank you.
Thank you, Rajiv sir. I think you and Sunil have compiled it all together at a very good note, that there's a need to all of us for us to come together and take all the concerns and points forward. So I will not take much time to concise this, because I think we have been discussing this for the 2 hours now. So me saying the same thing would not be much of an effort. Before we log off, I just request all of our panelists who are here and also the participants who joined us to switch on your camera just for a second, so that quickly we could have a one photo session over a webinar, and then we log off. Dr. Nayanjit, would that be okay with you? Okay, so I'll just, yeah.
You did not caution us to smile. Can you smile again? Is that possible?
Yes, please.
Okay, thank you. Is it over now? Thank you.
Yes, thank you so much, Rajiv sir, and thank you so much, all.
Thank you, everybody.
Thank
Thank you very much. Yeah, bye.
Thank you.
Thank you.